Hi friends, today I will talk about orthostatic hypotension. First is the disclaimer. Caring Doc's YouTube channel does not provide medical advice and information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only and it should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention and treatment of medical illnesses. There is no endorsement for any brand or a company. Orthostatic hypotension is a drop in blood pressure by more than 20 mm of mercury or more than equal to 10 mm of mercury diastolic. uh, Drop in blood pressure by more than equal to 20 mm of mercury systolic or more than equal to 10 mm of mercury diastolic within 3 minutes of standing from lying down or during 60-degree head up tilt. It is called orthostatic hypotension, or we also call it as postural hypotension. The blood pressure may be mild. This BP drop may be mild and brief, but persistent orthostatic hypotension indicates serious underlying problems. Causes include autonomic failure, medication, and low blood volume. When the orthostatic hypotension is due to autonomic nervous system dysfunction, it is called neurogenic orthostatic hypotension. Non-neurogenic orthostatic hypotension is more common than the neurogenic. When we stand and large muscle contract, it causes temporary vasodilatation and a small fall in blood pressure within 15 seconds. This is called initial orthostatic hypotension. It occurs due to temporary mismatch between the cardiac output and the peripheral resistance. BP returns to normal in 30 to 60 seconds. Delayed orthostatic hypotension occurs after 3 minutes of standing and it suggests early or mild sympathetic dysfunction. We know that uh, baroreceptors, they play important role in blood pressure control. These are the sensors located in the aortic arch and carotid sinuses. They maintain the normal blood pressure by sending the signal to the nucleus tractus solitarius in the medulla via glossopharyngeal nerve, that is from the carotid sinus, vagus nerve from the aortic arch, and this nucleus tractus solitarius regulates the parasympathetic output by dorsal motor nucleus of the vagus and sympathetic output by the ventrolateral medulla. When we stand from supine position, there is some normal response to standing. On standing, the systolic blood pressure usually falls by approximately 10 mm of mercury and diastolic blood pressure rises by more than 5 mm of mercury. The heart rate increases by 5 to 20 beats per minute. Reason is 500 to 800 ml of blood pools in the legs and the abdomen, reducing the venous return and the cardiac output. Baroreceptors, they detect this and trigger the baroreflex. They increase the sympathetic activity, they decrease the vagal tone and increase the norepinephrine release, which causes vasoconstriction, and that improves the venous return and the heart rate. Uh, what are the clinical features of the orthostatic hypotension? The orthostatic symptoms on standing are: patient feels lightheadedness, dizziness, blurred vision, weakness, fatigue, cognitive slowing, pre-syncope, that is near fainting. The other symptoms are orthostatic headache, that is pain in the head, neck, shoulder, which is relieved by lying down, orthostatic dyspnea, which is the breathlessness due to ventilation perfusion mismatch, angina even without the coronary artery disease. Symptoms may worsen with heat exposure, exercise, prolonged standing, heavy carbohydrate meals. The severe orthostatic hypotension We see syncope, that is fainting. It may be sudden or with warning sign. Associated hypertension, that is supine hypertension, common in neurogenic orthostatic hypotension. Treating the orthostatic hypotension may worsen the supine hypertension and vice versa. Patient may pass large amount of urine at night more than equal to 5 times. This leads to volume loss and there is worsening of the symptoms in the morning. The causes of the orthostatic hypotension are neurogenic causes due to dysfunction of the autonomic nervous system. It is seen in neurodegenerative disorders like Parkinson disease, dementia with Lewy bodies, multiple system atrophy, pure autonomic failure. Patient may have neuropathies like diabetic neuropathy, amyloidosis, autoimmune inflammatory neuropathies, for example, Sjogren's syndrome, paraneoplastic neuropathies, ganglionic acetylcholine receptor antibody, associated neuropathy. Other neurogenic causes are vitamin B12 deficiency, familial dysautonomia, aging due to impaired baroreflex, dopamine beta hydroxylase deficiency. All these are the neurogenic causes. Among the non-neurogenic causes, the non-neurogenic orthostatic hypotension is more common than the neurogenic. The non-neurogenic causes include drugs, intravascular volume depletion. Among the drugs, diuretics, alpha blockers, antihypertensives, nitrates, vasodilators, dopamine agonists, anticholinergic drugs, tricyclic antidepressants, they all produce the orthostatic hypotension. Intravascular volume depletion due to dehydration, vomiting, diarrhea, hemorrhage, poor fluid intake also contribute to orthostatic hypotension. The other causes are large carbohydrate meal like postprandial hypotension, alcohol use, and chronic kidney disease. The neurodegenerative disorders like Parkinson disease, they occur due to alpha synuclein protein deposition in the neurons. In multiple system atrophy, alpha synuclein deposits in the glial cells. The triad of multiple system atrophy is severe orthostatic hypotension, urinary symptoms, motor problems like atypical Parkinson's or cerebellar signs. Dopamine beta hydroxylase deficiency causes very low norepinephrine levels in the blood and low metabolites like metanephrines, normetanephrines, vinyl mandelic acid in the urine. Patient in the childhood can have vomiting, dehydration, hypothermia, hypoglycemia. Patients in the adulthood, they present with orthostatic hypotension, exercise intolerance, drooping of the eyelids, nasal congestion when lying down, neuropsychiatric symptoms, sweating remains the normal. It is mediated by the cholinergic fibers. There is a term called postural orthostatic tachycardia syndrome. The orthostatic symptoms without a drop in blood pressure but with excessive tachycardia. The heart rate increases by more than equal to 30 beats per minute in adults and heart rate increases by more than equal to 40 beats per minute in children less than 19 years of age. The mechanism of postural orthostatic tachycardia syndrome is reduced peripheral vasoconstriction because of decreased venous return, and there is reflex increase in norepinephrine which leads to increased heart rate. It is common in women. Symptoms, they worsen with illness like viral fever, surgery or post trauma, heat exposure, prolonged standing, and menstruation. These spots can also occur due to mechanical issues like loss of venous valves. How do we approach the case of orthostatic hypotension? First, we have to confirm the diagnosis, measure the blood pressure and pulse after 5 minutes of lying, again at 3 minutes of standings. The diagnostic criteria fall in the systolic blood pressure by more than equal to 20 mm of mercury or fall in diastolic blood pressure by more than equal to 10 mm of mercury. May or may not have increase in pulse rate more than 15 beats per minute. If the patient cannot stand, do the tilt table test at 60-degree head up tilt. Step 2 is the detailed history and examination. We have to document the orthostatic symptoms which I have already discussed. We have to see whether he is taking any antihypertensive or any other drugs like antihypertensive diuretics. They all cause orthostatic hypotension. We have to look for other comorbidities like cardiovascular or neurological comorbidities, and we have to do the systemic examination of CVS and neurological examination. In elderly, we have to rule out neurodegenerative disorders, volume depletion, for example, overuse of diuretics, and we have to look for polypharmacy also, because elderly, they take multiple medications for different comorbidities. We have to rule out the common causes. For example, uh, for syncope evaluation, we have to exclude the seizure, vagal attack, that is neurocardiogenic syncope. Common non-neurogenic causes like medication, anemia, volume loss due to vomiting, diarrhea, dehydration, all these are to be excluded. We have to assess the contributing factors like alcohol use, as we know that alcohol causes diuresis and there is loss of vasoconstriction acutely. Groaning intake leads to sensory motor polyneuropathy and vitamin deficiency. Peripheral autonomic dysfunction because of small fiber neuropathy. Patient may have burning pain in the distal limbs, color changes due to poor blood flow, systemic diseases causing the orthostatic hypotension like diabetes, mellitus, amyloidosis, porphyria, B12 deficiency, renal failure, autoimmune or paraneoplastic syndromes, they have to be excluded, and they also contribute to orthostatic hypotension. How do we identify the neurogenic or orthostatic hypotension? If there is severe orthostatic hypotension without adequate heart rate increase, it indicates baroreflex failure. The symptoms suggestive of autonomic failure are impotence, bladder dysfunction, gastroparesis, impaired sweating. The neurogenic orthostatic hypotension has threefold higher mortality. The non-neurogenic orthostatic hypotension has mortality similar to general population. How do we investigate a case of orthostatic hypotension? We have to do complete blood count to rule out the anemia, fasting and postprandial blood sugar, HbA1c to detect the diabetes. To assess the renal function, we do urea creatinine. We have to do the liver function test. We have to look for B12 deficiency and HIV and immunological test. Autoimmune paraneoplastic panels has to be done to rule out the autoimmune or the paraneoplastic causes. We have to do skin biopsy to detect small fiber neuropathy. Nerve conduction test do not detect small fiber neuropathy. Thermoregulatory sweat test raises the core body temperature by 2 degrees Celsius. When there is distal anhydrosis, there are chances of small fiber neuropathy. Central anhydrosis with distal sparing is seen in multiple systemic atrophy or Parkinson disease. MRI brain for neurodegenerative disorder has to be done, and standardized autonomic testing, it is useful in suspected neurodegenerative orthostatic hypotension. How do we manage the orthostatic hypotension? The general principles are: for non-neurogenic orthostatic hypotension, this can be treated by correcting the hypovolemia, stopping the BP lowering medication. For neurogenic orthostatic hypotension, the goal is symptom control and improving the quality of life, not normalizing the blood pressure. It depends on the severity and the comorbidities. No drug has to be proven to be improve the long-term outcome or survival. Treatment is mainly non-pharmacological. The physical maneuvers like squatting, crossing legs while standing can raise the blood pressure temporarily in autonomic failure. The non-pharmacological management include the support garments, for example, compression stockings, thigh or the waist high, abdominal binders. Sorry, I will just again read the non-pharmacological management. Uh, First is the supportive garments. We can use compression stockings, abdominal binders. They reduce the venous pooling in the legs and the abdomen. Physical conditioning of the body can be done. For example, exercise in shoulder deep water. It reduces the gravitational blood pooling by 75% and improves the brain perfusion. But necessary precaution has to be taken that person should not stand out of the water suddenly, as it may worsen the orthostatic hypotension. The cool water exercise is better than the warm water. It avoids the vasodilatation. Recumbent bicycling is also useful. The dietary measures are drinking 500 ml of water rapidly increases the blood pressure by 30 to 40 mm of mercury. It acts within 5 minutes, peak at 40 minutes, and effects last for about 90 minutes. It should be taken on walking. At, it prevents the morning orthostatic hypotension. Before meal, water can be given because it prevents the post meal hypotension. Before blood donation, patients who have history of syncope after donating the blood, the chances are reduced. Extra salt of 6 to 10 grams per day plus water 2 to 3 liters per day works best with fludrocortisone. Fludrocortisone is advisable in the orthostatic hypotension cases. Patient should avoid large carbohydrate meals because it lowers the blood pressure. Sugary foods and desserts, they worsen the orthostatic hypotension. They should be encouraged to take frequent small meals. Such patients should avoid alcohol. They should avoid heat exposure to prevent the vasodilatation. The pharmacological management is the fludrocortisone. It increases the blood volume by sodium and water retention. It sensitizes the alpha-adrenergic receptors to norepinephrine, hence it increases the vascular tone. The dose of fludrocortisone is 0.05 to zero point 0.1 milligram daily. It and we can increase it by 0.05 milligram weekly up to 0.2 milligram per day. The effect usually takes 1 to 2 weeks for complete effect or full effect. Now it is less preferred due to long-term side effects. We use adrenergic agonists. They raise the blood pressure during the daytime without causing night hypertension like fludrocortisone. We can use midodrine. It is alpha 1 agonist. It is a prodrug. It is converted to desglymidodrine in liver, and it is effective within 1 hour. The effect lasts for 4 to 6 hours. Dose of midodrine is 2.45 to 10 milligram every 3 to 4 hours. The side effects are the piloerections, urinary retention, as it does not crosses the blood-brain barrier. The CNS effects are very few. We can use droxidopa. It is a prodrug of norepinephrine. It is converted by L-amino acid decarboxylase. It is useful especially in the DBH deficiency, that is dopamine beta hydroxylase deficiency. The peak effect is seen at 5 hours. Other drugs with mild benefits are pyridostigmine and the octreotide. Compassion is the best medicine we can offer. With this, I conclude my today's topic. Thank you. Keep learning.